Perfect.
Welcome, everybody, to Optometric Education Consultants National Webinar Series, Sunday night edition. Tonight's topic will be advances in the diagnosis and management of atrophic age-related macular degeneration. And our speaker is Dr. Chris Putman, who got his Doctor of Optometry from Pacific University. He is commissioned as part of the Health Professions Scholarship Program, completed a U.S. Air Force Optometry Residency Program, and was awarded board certification in 2009. He is a noted lecturer, author, and educator. Currently, he's Medical Education Training Campus Department Chair for Diagnostic and Public Health Services, overseeing 9 programs across radiology, laboratory, public health, and behavioral tech training. So he has contributed a lot to our understanding. He has contributed a lot to our military, and we do thank him for his service. So with that, please, Chris, take over and tell us all we need to know.
Yes, sir. Well, thank you, everyone. I'm really excited to be here tonight, and I appreciate OEC for the invitation. So with no further ado, tonight we're going to talk a little bit about some of the advances in diagnostics and really focusing on some of the subclinical efforts and some of the diagnostic tools you have in your clinical lane and in your practice now. So going forward, very first thing, I'll put a polling question up there. So in your daily practice, do you currently utilize subclinical AMD diagnostics? And so think about this for 1 second, because I think you might be surprised that you're probably all doing it right now, but I'm going to show some of the evidence-based literature on how you can interpret that data and how you can make clinical decisions based on those results.
Is your daily practice, do you currently utilize subclinical AMD diagnostics? The polling questions are rolling in here, Chris.
Perfect.
Usually when we do a polling question, we check to see if there's any questions at this point, but there are no questions at this point, just people saying hi.
Very good. We've only had a single slide, so I hope there's not too many questions I've generated. So, all right. So in the interest of time, I'll keep pressing, and then Dr. Caldwell, if you have results you want to talk about, or if there's questions, please interrupt me at any time.
Okay, I'll let it go for a little bit, and then I'll let you know.
So I put this up there, not necessarily to become insulting to anyone, because I'm going to show a study that is ophthalmology and optometry, but I put this out there because I think a lot of us, myself included, we get very comfortable with our clinical routine. We get very comfortable with the way we were instructed, the way we learned in either optometry school or residency. That's the way we practice. So from that, I would encourage us to take just a moment to look at this study. So this one came out in JAMA Ophthalmology, and what it was ophthalmology and optometry, and it was essentially 31 different providers, and they saw a subject subset that had suspected AMD, and they were asked to define, was it mild, intermediate, or advanced atrophic AMD? And if you can see, essentially 25% of the eyes that were deemed normal on dilated fundus exam, in fact, did have AMD revealed by photography. And of those, 78% of the undiagnosed AMD fell within the AREDS 2 or 3 criterion that would make it treatable with our current understanding of the AREDS 2 formulations and some of the nutraceuticals. And so this is not meant to be insulting, but the reason that I put this up there is because that red circle, I think sometimes, especially working at the University Incarnate Word with the 4th years and some of the residents, we get entranced by the fovea. That macular pigment is what we really focus down on. But what I would encourage you to think is that is the clinical macula. So in fact, where we start to look at the fovea and think macular pigment, that is just the fovea itself. The green circle, in fact, anything within the green circle would be clinically defined as maculopathy. And so this is essentially my left eye. But if you look at that, the macula is 5.5 millimeters in diameter. The fovea is 1.5 millimeters. And the foveola, right where you start to see that the foveal light reflex at the very center of the umbo, that essentially is only that single degree, that single visual degree wide. So starting everything off today, kind of consider when you're looking at your patients and even thinking back, the macula itself is much larger in general diameter than I think we sometimes appreciate at the slit lamp. So here's going to be our kind of rules of engagement tonight. We're going to look
Let me,
closely
let me
at,
give you your
Yeah.
polling results here so we can have them and we can be ready
Absolutely.
for your next one. So 49% answered yes to your question, 20% said no, and 31% are unsure. So that's good that we are here tonight doing this.
Absolutely. And that's very fair. And I think what we'll do is just for also setting expectations, I'm a big evidence-based practice guy. So all of the slides available today are meant to be a repository or a reference for you. So all of these slides are available, and virtually all of the literature we're going to review comes from the peer-reviewed literature, primarily meta-analytics and a lot of the review articles. So looking at that spectral domain cross-section, it's really the Henle fiber layer that we're going to spend some time on today, because the Henle fiber layer is the OPL in the macular region, and that's really the dense concentration of the photoreceptor axons. So that is where a lot of the mitochondria are going to live within there. And you're going to start to see that when we get into AMD ground zero, I'm going to ask everybody to maybe rethink a little bit of what we think of as epidemiology and risk factors when it comes to early subclinical development of age-related macular degeneration. And then we're going to just look at a little bit of the OCTA. So even if you're not utilizing OCTA on a daily basis, even if it's not a technology that you're overly familiar with, what spectral domain OCT is now, SWEP source, and especially OCTA is going to be here in the next, I would even speculate, 5 to 7 years, because a lot of the new devices have this software embedded within the hardware itself. So what we're going to find is a lot of what we believe to be atrophic AMD essentially is subclinical neovascular changes. And I can give some tips and tools on how you can even differentiate that right now, even if you don't have an OCTA in your practice. And then just moving into this, so also just looking at AMD from a structure versus function, because coming from Pacific University, as I'm sure all of us went to optometry school, it was really, really clear that there was a structural ophthalmic approach, and then there's a functional ophthalmic approach. And so when we look at age-related macular degeneration, primarily we're going to look at not only the structure, which I think we're all very familiar with, the drusen, so the pill, the photoreceptor integrity layer, which is effectively the ellipsoid zone. We'll look closely at that in the literature and how that diminution, how changes to that ellipsoid zone early actually show that there is some oxidative stress and some changes to the macula that may show impending early maculopathy. And then especially when we get into dark adaptation and contrast sensitivity, because I think contrast sensitivity, unfortunately, is an underutilized capability that I can show some evidence at the very end that you can use this right now. And there's a stark difference between a cataract related loss of contrast sensitivity versus a maculopathy loss of contrast sensitivity. And I can help you differentiate that and show you the data here today. So from an epidemiology, here's the part where I'm going to put a little bit of the new data out there, because I think going forward, we're very familiar with AMD and its epidemiology. So going way back to 2001 from the ARED study, that was really where we started to identify how many Americans were at risk, how many showed the condition, and how many showed mild, intermediate versus advanced atrophic. And so we're going to talk a little bit about genetic predisposition, but I think some of the things that I'll really spend some time on today is the underlying inflammatory conditions, as well as some of the underlying cardiovascular risks that should really be part of all of our patient intake. When you're doing a review of systems, when you're doing a review of medications, start really keying in on some of these underlying systemic conditions that shows an odds ratio. There's a significant risk of development of AMD if these patients have cardiovascular disease or have a systemic inflammatory condition. And I'll show you that right now. And then going forward at the very end, when we start to round this out, so what? I know I have it. I know there's some issues going on, but what can I do about that? And we're going to talk about some of the new technology, not only that's being rolled out in the European Union, that's undergoing trials here in the US right now, but some of the nutraceutical strategies and some of the oral supplement strategies that have peer-reviewed evidence and have for the last 10 to 15 years. So I'll share that tonight as well. So here's the first one that I want to talk about. Essentially from a major disease category, AMD has one of the strongest familial links of any of the major diseases. And so if you look at the number of cases of AMD versus open angle glaucoma and diabetic ret, AMD dwarfs them both. It's in fact the number of patients that are going to pass through your door that have a risk of development of AMD or have AMD features, in fact, is higher than both your glaucoma and your diabetic retinopathy patients. And so the big part that I want to look at is when I put the boxes around, you can see that of the risk alleles, the complement factor cascade, that's the two new geographic atrophy drugs. They're both complement factor 3 inhibitors. But you can see that those are the risk alleles. But even more importantly, going down below that, you can see that the dyslipidemia or hyperlipidemia risk alleles, that's really where this starts. This is the subclinical changes at the level of Bruch's membrane and RPE that put that retina at risk for development of maculopathy. And we're going to show that here right now. The other
Hey,
one,
Chris,
I think,
really cool. Just when you said that, my son, he's a junior at St. Francis, took his genetics course this year, and he was all excited to come home and say, "Oh yeah, we talked about macular degeneration today and the penetrance and this and that," and that's so it seems to be that's what the genetics people when they teach it in college now, because it has such a high conversion or high penetrance through the families.
it really does. And in fact, if we get into it, a little bit of the epigenetic factors and some of the protein, some of the regulated protein expression, that is where the real triggers lie. And in fact, that was a perfect setup. Thank you, Dr. Caldwell, because we're going to get into that very thing here right now. I think the interesting thing too here is when we talk about risk and especially epidemiologic risk, it's not static. Because I know even going through school, even through residency, you would have your big risk factors. You would ask the patient about, family history, first degree relative, or they smokers, and all of the standard questions. But interestingly, this back in 2016 started to show that your lifetime risk, no maculopathy, just family history, no maculopathy, you can see how your lifetime risk rank ordered. So the red is the essentially the inflammatory, the blue are lifestyle modifiable factors, and the yellow essentially is some of the lipid depositing, some of the cassette carriers that allow cholesterol to build up at Bruch's and RPE interface. And you can see that lifetime risk is one order, but if you are diagnosed with macular degeneration, if you start to have some subclinical changes, mild changes even, you can see that how that shifts rapidly, that suddenly it's about lifestyle modification and it starts to become more about the lipid deposition. So there's some things that you can do, especially when you're seeing patients on a primary care basis. Almost at the very end, I'll show you the checklist that I like to use, that we use with our residents, of how to really just walk through those steps to ensure that you're asking the right questions to kind of set up, engage in almost predictive risk over the next 5 years. And so the other one that came out, and this one is very new, this one just came out in the last 3 months. I think another one that we sometimes overlook a little bit is if that patient also has a systemic inflammatory condition. So you can see that this was using a nationwide database using the ICD-10s, and what they were looking for is the immune-mediated inflammatory disease. And you can see under the results, essentially a relative risk. So essentially there's a 50% increased risk if they have an immune-mediated inflammatory disease. And you can see the breakdown. It would be surprising if on the line tonight, we don't have people that have multiple patients with those conditions. You can see ulcerative colitis, Crohn's, psoriasis. You can see a number of these conditions. These, in fact, are setting that patient up for a higher risk, and especially if they have a family history, this almost needs to be a checklist, just making sure that if this is a concurrent condition in a high-risk genetic individual, they are at greater risk right off the bat of developing age-related maculopathy. And then moving out of epidemiology, I know it gets dry and I know it's tabular, and everyone has seen the AREDS criterion. But I think the important part here is when you get into AREDS 2 and especially AREDS 3, those are where the literature has told us that the AREDS 2 formulation, some of the nutraceuticals, this is where the AREDS 2 that came out of Emily Chu and others, this is where we as primary care optometrists really need to do our best, because you can start to see that drusen size, 63 to 125 microns, That's not very big. And especially when you start to consider that it's not the fovea, it's not the 1.5 millimeter, it's the 5.5 millimeter zone. So if you open the aperture, so to speak, and you start to apply the same AREDS criterion to that larger diameter in the back of the eye, you might find that some of your patients are beginning to fall into an AREDS 2 or an even AREDS 3 atrophic AMD. So polling question number 2, it's important enough that I've hammered on it already, but I thought I would put it out there just to see if everyone is still awake and paying attention. But clinically speaking, what is the approximate diameter of the human macula? Just because everything is relative. So the human optic nerve, right, is approximately 1.8, 1.9 millimeters, slightly vertically elongated versus horizontal, but about 1.8 millimeter. So when you're thinking of the back of the eye, the macula encompasses a little bit larger area than I think, at least myself included, have given it credit for in the past.
Yeah, it is true, Chris, because I've done polling questions asking on webinars like this before you kind of reviewed it. So it would say, which is the macula, A or B? Is it A, B? And I think it was like blue and yellow or whatever. So I flipped back and forth. The majority of the people would they thought the fovea was the macula. So I agree.
And it gets it's enticing, right? You see the macular pigment and you're like, well, it's macular pigment, so it must be in the macula. And you really you miss the forest for the trees, you really focus into that area. But expanding that zone to the full clinical macula, you're going to find there's a little bit more maculopathy out there than maybe what we have realized.
So the majority of them have placed 5.5, 76%. You have one at 0.3, one at the optic nerve, 1.5, 7 responses, and then 2 unsure. So you did a good job of getting your point across there.
Well, sir, I guess my job is done here. If there's any question, no, just kidding. So what we'll do is we'll move on to some of the related findings. And these are really the related findings as subclinical findings. So what I want to talk about here is what goes on before that 63 to 125 micron drusen becomes visible. What's actually happening at the retinal layers that structurally may be invisible to us because we don't have the resolution and we're not looking for it. But functionally, that's what we're going to talk about right now. So the microvascular changes, because this is that one where I had mentioned OCTA, it's coming. It is out there now in a number of devices, and OCTA normative databases are now being embedded within these devices. So now, just to kind of whet your appetite, so to speak, swept source resolution is almost twice as high. So you can get down to the almost 2 to 3 micron level. And this is where it's going to become very important, because what we're finding is the vascular underpinnings, both the superficial capillary plexus and the deep capillary plexus, when you start to see an increasing of that foveal avascular zone, when you start to see a loss of vascular density, this is preceding any type of visual functional changes. This is far preceding any type of drusen development that you might be seeing at that RPE level. And I think the important thing here is, if you ask if I don't have an OCTA, the interesting thing is this OCTA, these vascular changes, they actually underlie on a spectral domain when you start to see thinning of these same layers and when you start to see that loss of the ellipsoid zone. And I'm going to show you that evidence right now. So really, the vascular, microvascular changes, that is the early stages of subclinical age-related maculopathy. And here's when we get into the RPE dysfunction, because I'll have some slides in a moment. But the BLIN-D and the BLAM-D, these are perhaps cholesterol, these are perhaps deposits that you haven't been familiar with, but these are the precursors to the drusen that begins to build. And so you can start to see that the basal laminar versus the basal linear, where they begin to deposit. And they essentially are beginning to deposit right at that Bruch's membrane and right at that RPE level. And so this is where you start to get dysfunction of the visual cycle. So we're all very familiar with cis, trans, retinol, and how the visual cycle and phototransduction works. But this is where you start to get that cholesterol deposition at that Bruch's RPE junction. And this is why things like dark adaptometry, your inability to recover to bright stimuli because that visual cycle is affected, it's because you're getting this thin line of early cholesterol deposits. And this was a really interesting study that came out in 2018. So they're quite literally comparing it to an oil spill. You have a cholesterol layer that's building up right there at the Bruch's membrane and right at that RPE interface. And so for your patients that have a hyperlipidemia or a dyslipidemia, they're taking a statin because a vast majority of our patients are on a statin regimen. These are the questions that you want to start asking, because if they have an existing inflammatory condition, if they have an immune-mediated inflammatory condition, and they have high cholesterol, and they have a cardiovascular history, they are checking all the bad boxes for development of AMD, and especially subclinical AMD. And if you look at the BLIN-D, so the linear deposits, apolipoprotein B and apolipoprotein E, you can see ApoE, that is another big risk factor in Alzheimer's and related dementias. And we're going to talk a little bit about the crossover here as well, because there's some emerging evidence that some of the changes at the retinal level not only show cortical changes related to Alzheimer's disease, but they in fact share a very common pathway. And I will wrap that all up here in a moment. But bottom line on this one, this is where asking your patients about their lipid status, about their inflammatory status, essentially about their cardiovascular status, these become very critical pieces in your decision puzzle.
Chris, before you go too far,
yeah.
Right there at that picture, that was awesome. You've talked already about the mitochondria, the photoreceptors, the ellipsoid zone, so on and so forth. But also down here at the base of the RPE, I'm not sure what those purple things are supposed to be, but there's a high concentration of the mitochondria. That's where they are. That's where they live at the RPE, which I think it's always kind of neat that the mitochondria are always linked to aging and anti-aging. And so where the mitochondria are living in the RPE is right there where this kind of macular degeneration kicks off.
Absolutely. And Dr. Caldwell, you're exactly right, because what happens is in a lot of these degenerative conditions, you get a mitochondrial dysfunction. And once that mitochondria, especially at the RPE level, starts to fade away, that's where you start to lose the autophagy. That's where you lose the phagocytosis and the discs and the essentially shedding discs from the cones and rods. They're not being phagocytized, so you're getting a toxic buildup of intracellular debris, and that's only exacerbating the process. So Dr. Caldwell, you're exactly right. When you get a loss of that mitochondrial function, that whole cellular biology is starting to fail even before you would see drusen, even before you might see visual effects. But this is happening now. So asking these questions subclinically, I think, is crucial for our patient management. And so just a couple of graphics here. So that's a healthy choriocapillaris, Bruch's, and RPE. And you can see on that left side is that kind of thin red line. You can see the vasculature, the choriocapillaris below it. But it's that line right below the RPE that I want you to focus on. So that's healthy. As you start to get that oil spill, as you start to get those cholesterol deposits, you're still not seeing anything on the right. You're still not going to see the drusen changes. You're still not going to see the dropout, any kind of macular pigment loss. You're not going to see that quite yet, but that cholesterol is building now. As that continues to degenerate, and as Dr. Caldwell mentioned, as you start to lose that mitochondrial function, you get more degeneration. But even now, even after this time, you're not seeing clinical evidence of the drusen. And so often that's what we're looking for. But in fact, I would ask everyone online tonight to maybe even step back further. And even if that macula is looking healthy structurally, what about functionally? And I think functional is where we need to go. And I'm going to show some of that in just a moment.
And so Chris, if you want to use your pointer, it will be able to be shown on TV.
Oh, absolutely.
Not TV, but the screen. Sorry.
Yep, absolutely. But so here is really my take-home point. So by the time you start to see clinically evident drusen, where you really start to see changes on gross ophthalmoscopy or your high plus, you have already had a significant amount of degeneration, not only at the Bruch's RPE level, but now that BLIN, that BLAM, that cholesterol deposition has now coalesced into drusen deposition, clinically evident drusen. But from what we've seen, this is not early, this is late stage. This has been going on for some time. And so wrapping this all together from an epidemiologic standpoint, geographic atrophy, I think, is the one where much like we know from foveal sparing diseases. The reason the fovea tends to be spared and why in geographic atrophy, the multifocal atrophics versus extrafoveal lesions tend to predict geographic atrophy is because these retinal carotenoids that we're going to talk about in a moment, the retinal carotenoids are at their most dense, their highest optical density right at that foveola. So that's where those macular carotenoids are offering their greatest free radical and singlet oxygen protection. So you tend to have a little bit less protection as you go eccentric from the foveola. So that's why individuals that start having multifocal atrophic spots, not at the fovea, but within the macula, and especially when they're extrafoveal, where there's less retinal carotenoid density, that's where you start to see the high risk of a geographic atrophy development. And as we mentioned, it's that choriocapillaris, when you start to have that microvascular degeneration that underlies the RPE, it's or essentially it's overline, but it's that microvascular loss that can be measured through OCTA at the superficial and the deep capillary plexus. It's because that choroidal, that microvascular circulation is being impaired. And so it's already starting to spill over into that metabolic dysfunction that's leading to even more potential risk for geographic atrophy. So you start to get this almost snake feeding on its tail into a downward spiral. So really, before we move too far into some of the studies, here's really the take home. So early onset pathogenesis, if you took nothing else from this first section, drusen are not markers for early AMD. Visible structures indicates it's been going on for a while. So here in a moment, we're going to start talking about subclinical indications and what you can do with not only your imaging devices, but what you can do chairside, what you already have in your arsenal, plus your clinical acumen and experience, how you can kind of bring this all together and start to put together 5-year risks for some of your patient population. And you can start to see the cholesterol deposition that precedes much of this. It's not really a structural test, but functional testing. I'm a dark adaptometry fool. I think dark adaptometry, is one of my favorite clinical tests, and I'll show you that in a moment. But dark adaptometry, you can identify vitamin A deficiencies that are systemic. You can start to identify functional changes at that fovea, and more importantly, at the macula that are already indicating bad news is on the way. And so as that cholesterol accumulates, you're going to hear this over and over as well. Inflammation, oxidative stress, and the disruption of the mitochondrial function. When you start to have some loss of mitochondrial function, that's where you'll start to set the stage for drusen deposition, followed into intermediate, advanced, and potentially geographic atrophy. So early intervention is going to be the key.
And Chris, I'm going to feed off it as you're going to the next slide. Is a lot of people might say, okay, I can catch this early. I can't use AREDS 2 until, it's intermediate advanced. So what's the big deal? And this is where I've moved into the last few years of speaking. This is that anti-inflammatory lifestyle. We can coach these people. We can get them, the 3 pillars of health: exercising, recover, good nutrition, right? You got to get them exercising, recover, good sleep. You heard a ton about sleep, breathing exercises, so on and so forth, parasympathetic, sympathetic, and good nutrition. And to me, as you know, comprehensive antioxidant therapy, fish oil early on for these people. So I just kind of want to set the stone. A lot of people might sit there and go, set the stage is that, okay, it's great to catch it early, but there's nothing we can do. Absolutely, there's things that we can do.
Yeah, no, that was a perfect segue as well, because I would never leave anyone on the line with bated breath. So I promise that I will show you not only what the evidence-based practice reveals, but also what I use clinically in an almost checklist stance. Because as they mentioned early, I'm active Air Force. Pilots with 10,000 hours in the cockpit, they use a checklist. It's not because they don't know how to fly the aircraft. It's because using a checklist helps minimize mistakes and helps ensure that you are making a maximized effort at doing everything right every time. So we're going to go right into that right now. So just a quick breakdown of the AMD studies. This is only this is an iceberg. This is the very tip top of the iceberg. There are hundreds and hundreds of studies, but the 4 that I want to talk a little bit about today, I think, are the 4 that will inform not only this lecture, but what you can bring to your clinic tomorrow. So the EDCC, so the eye disease case control, this kind of kicked everything off. So you heard me mention retinal carotenoids earlier. So retinal carotenoids, even back in 1994, from this essentially this survey, this food questionnaire survey, it was identified that the highest dietary intake of retinal carotenoids essentially had a 43% risk lowering of advanced AMD. And I think that was from just a food questionnaire. This was kind of the base setting of where these next studies came in. But I think the really interesting note is once you start looking at the data, they identified early on that vitamin A, vitamin C, and vitamin E didn't show a relationship to early AMD development. And that might sound like, okay, what does that mean? But interestingly, that's exactly what AREDS and AREDS 2 are showing us, that really clinically indicated AREDS 2 formulations are clinically indicated for intermediate and advanced atrophic AMD. In zero maculopathy or mild maculopathy, there's really not a clinical indication. And this, even in 1994, showed us that it has a lot more to do with the retinal carotenoids, the polyphenols, and the omega-3 fatty acids, including DHA and EPA. And I will show you the dosages and frequency here in just a moment. So AREDS 2, so this is really what started from primary care optometry. This is the AREDS genesis. So this was a 5-year longitudinal study. It obviously has been dissected and churned up and mulched over many, many times. But I think the important thing to see here is 20-year follow-up from this same longitudinal study. So the surviving members of this original cohort are still showing support for that 20-year study. The one point I would bring to you is I put it in red, that 80 milligrams of zinc does have some potential risk. That's the reason copper is included, is because zinc essentially depletes copper within the metabolic system, and copper is a critical coenzyme. So that's why copper was included, is to offset the amount of zinc. And the AREDS 2 showed us that much zinc isn't necessary. And we'll talk more about that in a moment. But this is really the crux, that the AREDS formulation shows value even 20 years later. And so from an AREDS 2, this is where they entered into some of the omega-3s and then also the retinal carotenoids, specifically lutein and zeaxanthin. And so this is one where I think I was still in graduate school. So I was at University of Missouri, St. Louis, working with Dr. Bassi when we were building our retinal densitometer for spatial mapping. And when this came out, it was kind of like a big thud, because everyone was expecting a very strong impact of adding the lutein, zeaxanthin, and omega-3s, but it wasn't as shocking as they'd hoped. But I would say, if you look closely at how the data was broken down, when AREDS 2 was published, you can see the 4 arms they divided their individuals into. So that means they divided their individuals into arm 1, arm 2, arm 3, and arm 4. And you can see that arm 4, which they deemed a control, really wasn't a control at all, because these are individuals that AREDS 2 subjects were previously diagnosed with moderate to advanced AMD. So essentially, this is a different cohort than AREDS 1. And all of those individuals already started on the AREDS formulation. So that means you just took the effect size of adding lutein, zeaxanthin, and omega-3s and not taking anything as a placebo. You shrunk it because there was no placebo. They already put them on a known formulation that had retinal benefit for intermediate and advanced atrophic. So I think that when we looked at this, we're like, oh, geez, what a thud. But if you really dig into the data, you can start to see that when they put the retinal carotenoids in place of or substituted for beta carotene, you can see that the retinal carotenoids had an 18% risk reduction of advanced AMD. They had a 26% reduction in neovascular AMD in the lowest cohort, and a 22 overall risk reduction in neovascular within 5 years. So I would argue that, in fact, the addition of the retinal carotenoids made a tremendous amount of difference. That's a significant risk reduction just by taking out the beta carotene, removing the small cell carcinoma and former smoker risk, and putting in a retinal carotenoid. You already had a bump to what you know works. And then here's the other kicker. There was no apparent reduction for zinc from 80 down to 25 milligrams. So some of those AREDS patients that have genital urinary issues, some of the patients that have OBGYN issues, there are concerns about using that level of zinc in there. And so by reducing it to 25 milligrams, you reduce that risk, but you have a negligible impact in the retinal value of that. And so here would be the last one that I put in. So we've already talked about the AREDS2 formulation, the addition of the retinal carotenoids, but here's the dietary flavonoids. And so if you're wondering what a dietary flavonoid is, to a large extent, imagine a Mediterranean diet. But you can start to see that if you took a solid look at what the flavonoids have to offer, this is a 2018 paper, but it was a 15-year prospective study. So they went back and looked at all of these individuals that had high polyphenol intake. And I'll show you exactly what that list here is in a moment. But all of the usual suspects are here. I put red boxes around what the dietary polyphenols play a role on. Reactive oxygen species, interleukins, tumor necrosis factors, JAK, VEGF is in there. So the polyphenols have a positive effect in reducing that chronic inflammatory, that chronic angiogenic environment by reducing the risk to an atrophic or an advanced atrophic. You're essentially just setting the stage for a lot less risk of progression by putting those polyphenols. And you can see the odds ratio. You have a 25, almost across the board, 24 to 25% risk reduction by adding the flavonoids in. So we're going to talk about the retinal carotenoids that live at the sensory level. These polyphenols, they tend to live down at the RPE level where AMD ground zero is located. So you're getting a good news sandwich for your patients if you consider both of these. And we'll chat about that here in 1 second. So the question has to be asked, why not use antioxidant therapy on every high risk? I mean, let's say I'm giving them an AREDS2 formulation. What's the risk? Well, the risk is essentially if they don't have the right genotypic expression, genotypic allele component, if they don't have the CFH and the ARMS2, essentially you get a little bit of you get less bang for your buck, so to speak. But as we talked about too, if you're putting them on high dose antioxidants, you essentially have prostate hypertrophy, genitourinary complications, and the evidence does not bear out that putting everyone on a high antioxidant AREDS2 has benefit. It's only clinically indicated if they have an intermediate to advanced atrophic AMD. So moving on to polling question 3, drusen formation associated with AMD development occurs at which layers? Bowman's layer, RPE Bruch's interface, photoreceptor, receptor axons, or the RNFL? So if you're all right, Dr. Caldwell.
The polling question is open. Answers are starting to roll in. So yeah, it's kind of warms my heart, Chris. I know you did your PhD in macular pigment, but to see that, we're getting beyond just lutein and zeaxanthin. I'm not a lutein and zeaxanthin hater, but I just think we can do so much more. It's just two of that's just part of those. Lutein and zeaxanthin are just part of this wide spectrum of antioxidants. So it's great to hear you talk about flavonoids and polyphenols and all this, because there is evidence out there that the retina needs that, the eye needs it to help with this mitochondria and this oxidative stress that we talk about.
Yep, absolutely. And so a lot of those high dose antioxidants are critical for the anti-inflammatory, but when we get into the polyphenols and some of the omega-3s, they're having their greatest mechanism of action at the RPE level. And it's that RPE that's under attack from day one. So in the interest of time, I'll keep rolling. So
you've got 95% saying RPE Bruch's membrane. So
wonderful. Excellent. If anyone shows
and
Bowman's,
caught up on the questions, and there's nothing in the chat, so you're good.
Okay, thank you, sir. I appreciate that. I was just going to give everyone a hard time. If anyone said Bowman's, please give me a call immediately after the lecture, and then we'll figure it out. So from a subclinical AMD diagnosis, this is really where the rubber meets the road. So we've talked about the epidemiology. We talked a little bit about the studies of when supplementation can be used and what supplementation we could potentially use. But how do I know when my patient is progressing into a functional or a structural change? What do I look for clinically? And so moving forward, as Dr. Caldwell mentioned, certainly I'm a little biased in macular pigment because I spent 3 years of my life in macular pigment. The jury isn't out on this one. High retinal levels of carotenoids have a protective effect. But I think where the interesting evidence is going is that the retina doesn't hang in a closet all by itself. That interestingly, serum levels drive retinal levels that drive cortical levels. But as a measurement to that, the serum levels also measure and drive skin levels. And there's a proxy measurement at the skin level that can say if the skin matches the serum, that matches the retina, that matches the cortex, they all do fall under an OC, so an area under the curve, like a receiver operating characteristic. It's about 0.83. So it's a fairly robust curve that if A equals B and B equals C, A equals C, and we'll show you some of the evidence in a moment. But I think that's very exciting going forward, that you don't necessarily have to image the retina itself for macular pigment. You can use proxy measures and still have a very strong idea of what their carotenoid status looks like. So here is another one that I just love to death. So Maculogics, I'm sure we're all aware, Maculogics did file for bankruptcy, but I will say the good news on this one, I believe it was in 22, Maculogics and all its proprietary data and devices was bought by Lumathera. And so Lumathera, we're going to talk about in a moment, but Lumathera works in the photobiomodulation realm. And if that's a term you're not familiar with, I have a couple slides on that. But the reason I say that is because the dark adaptometry, the reason I liked it so much is because it was a functional measure of retinal sensitivity. It was a way to measure that visual cycle that was impaired by the cholesterol deposition at Bruch's and RPE. If I had that barrier, that oil spill going on, there's really not a good imaging device to identify that. But functionally, the dark adaptometry allowed that. And for comparisons, you can see the sensitivity specificity. It was 91 specific and 91 sensitive. And that just sounds good off the bat. But if you compare that to what we use every day, Humphrey Visual Field, it's not as sensitive, a little more specific, but Humphrey Visual Field is a gold standard. Virtually none of us would manage an open angle or a glaucoma patient without a Humphrey Visual Field. You wouldn't manage hydroxychloroquine or a Plaquenil patient without a Humphrey Visual Field. And on top of that, slit lamp diagnosis by an AMD retinal specialist or just a retinal specialist, you can see that even the dark adaptometry, the functional measure of that retinal sensitivity, was still superior using dark adaptometry. And this is the reason I liked it so much. It was almost a crystal ball. I won't continue to beat a dead horse on this one, but you can see that if they had a failure, if there's 6.5 minute points, so there was a short screener and then there was a full run, but even using the screener, if you had an impaired dark adaptometry, essentially you had a 2 times more greater likelihood of developing clinically evident AMD, and you had an 8 times greater likelihood of being intermediate AMD. So in a sense, you had a figurative crystal ball that could tell you right now something's going on. And if we don't do something now, here's our trajectory. And so here is where that discussion can come in with your patients, because AdaptDX is still out there. You can still find either the VR version or the tabletop version, especially if you're managing an AMD population or a high-risk AMD population. This is where that early nutraceuticals, including retinal carotenoids, polyphenols, and some of the AMD or omega-3 evidence, this is where the difference is made. It's a trajectory. If I make a small change early in the trajectory, I can make an incredible difference 5, 7, 10 years down the road. So this device can allow that. So,
hey, Chris, let me make a comment on that, because when you say like the instrument in bankrupt, it sounds like the instrument might not be great. And I think you kind of said it, but I want to echo it. The instrument is a great instrument. I have the instrument. I love using it. What I think is that, we gave this instrument, which is an allopathic diagnostic instrument. And again, that's why I wanted to echo this early in the lecture, is that we don't really have a pill for that ill. Now we have to be doctors that feel comfortable talking about diet and exercise and nutrition. And we were never taught that. We were taught if you have a sty, you give them an antibiotic. If you have an iritis, you give them steroid. If their pressure is too high, you give them some type of drop that lowers the pressure, glaucomatous medication, or you do an SLT. So this, the instrument, I think, was when I was talking with these guys, the Maculogics people, Greg Jackson and all the inventors, is that, look, you have a great diagnostic, you just don't have that pill for the ill. The people are, most of the ophthalmologists and optometrists are going to feel uncomfortable discussing nutrition, exercise, and sleep and recovery. So I just want to make sure that the instrument is a great instrument.
Oh, absolutely. No, I can't honestly. It's dark optometry, and the theory is sound. The evidence is out there. So it was at Penn for a while, it was at Duke for a while. I mean, the evidence is out there, and you're exactly right. Now that we have that emerging evidence that a proactive stance on nutraceuticals or supplements, especially targeted nutraceuticals, you have an answer now. You have something in response to that finding of a reduced dark optometry. You're absolutely right. So here's where we're going to talk a little bit about the objective findings. So some of your structural findings you can find in spectral domain. So as we mentioned, that Henle fiber layer, so that's really kind of that OPL, which is the Henle fiber layer in the macula. That's really where the retinal carotenoids live. So those yellow bars right in there, that is your highest optical density of lutein, mesozeaxanthin, and zeaxanthin. And so that, I think, is important because we know that, but just kind of stepping back ecologically, it's really interesting that it tends to be pre-receptoral. There's a reason that it lives pre-receptoral in the way that it does, because from a retinal carotenoid standpoint, there's really three hypotheses. There's the protection hypothesis, there's the optical hypothesis, and there's the neuroefficiency or neurocognitive hypothesis. We won't talk a lot about the neurocognitive. That's a different lecture for neurodegenerative conditions. I will touch just briefly on the optical. The peak sensitivity of absorption of the retinal carotenoids or macular pigment is 460 nanometers. And 460 nanometers is dead in the middle of blue. And if you look at the daylight spectral composition, 460 nanometers is the peak of natural daylight. Natural sunlight peaks at 460 nanometers. So ecologically speaking, there's a reason that the macular carotenoids deposit in the Henle fiber layer at values 1,000 times higher than the serum. There's a reason they absorb that spectral range that they do, and there's a reason they're all pre-receptoral. It's because it's acting as a blue light filter on all incident light before it reaches the photoreceptors and Bruch's complex. So there is a reason that the retinal carotenoids live where they do. And so here we're going to talk a little bit about that green box. Talk about the ellipsoid zone. That's really where the mitochondria for the photoreceptors live. And then we're going to talk about that RPE Bruch's that we've already discussed. So here's where I think for those that are fortunate enough to have a spectral domain, I truly believe that spectral domain is primary care. It is almost standard of care for most disease-oriented practices. If you are managing whether it be optic nerve disease, retinal disease, I really think that spectral domain OCT is your bread and butter. It is a primary care, standard of care tool. And so this becomes the important part because utilizing the raster scans. So we've worked on Spectralis. I have a Zeiss in the university. I don't have a favorite necessarily, but having that optical cross-section and using the high-resolution raster scans makes a big difference because that's where you can really start to see some of these very subtle changes. So after we've had that oil spill, after we've had some of that RPE Bruch's membrane degeneration, after we've had some of that cholesterol deposition coalescing into drusen, that's where you can start to actually measure and see how big these things are. And the reason this becomes important is because it's that AREDS2 criterion, greater than 63 microns, but less than 125 microns. This is where it can really start to impact whether you're going to initiate a retinal carotenoid polyphenol only, or whether you're going to use the retinal carotenoid polyphenol plus the AREDS2 formulation. In my practice, I tend to err on the side of treat. So if it's right at 63 to 65 microns, I'm going to treat it like an AREDS2 criterion. And for example, on the next one, this one I think is a much easier patient. There's less left to the imagination, but you can see it's a much larger area of affected RPE. So you can see that drusen building up very, very frankly, but you can also see the broad expanse of that. And that's where that AREDS 3 or greater than 360 microns. So that's another discriminator that I would err, in my personal opinion and how I practice. I will tend to err on a little bit higher criterion because that's going to drive me. And if I don't have a chance, my fellow provider to look at that more strictly and with a little bit more skepticism and say, geez, is this progressing? Are we needing to intervene now? Are changes necessary? Do we need to enact some additional testing to make sure this progression is not as fast or faster than we believed it to be? And then further on too, you can see much bigger drusenoid depositions, and it has everything to do with those criterion. And the reason I keep harping on the criterion is because the criterion is evidence-based medicine. We treat based on evidence-based medicine. So that criterion that was in that dry table that I showed you initially, that's what drives our clinical decision-making. So I won't spend a ton of time in the OCTA, but I want to introduce just a couple things on this. So if you have an OCTA or ability to get the OCTA, as I mentioned, the underlying superficial and deep capillary plexes, when you start to have loss of vascular density, when you start to see changes in the size of that foveolae vascular zone, it's getting bigger and you're losing vascular density. That's a major risk factor. That is a big warning sign. And this is not just AMD. This applies to retinal conditions across the board. Diabetic retinopathy specifically, when you start to lose that vascular density, you may not see that retinopathy yet, but it's coming. This is a bellwether. This is the canary in the coal mine that it's changing. And I think the important part is, here are the studies to show that. So what becomes very challenging in a primary care optometry standpoint, if you don't have an OCTA, or if you're not measuring the superficial capillary plexus or the deep capillary plexus, even atrophic eyes, even eyes that appear to be atrophic, approximately 15% of them actually had some occult or classic neovascular nets beginning. You were actually, all of us may be at risk for not identifying these nets because they're very, very tough to see. They are very, very small, and they can hide even in a spectral domain OCT. And so I think it's important to know that always be critical of yourself and always be skeptical that it appears atrophic. It doesn't look like it's progressing. I don't see functional loss, but always second guess yourself. Is that atrophic change just a hidden neovascular change? And I need to test further, and I will show a clinical device that can help you with that right now. And then going on further, you can see that knowing that vascular density. So just on the topic of OCTA, knowing that vascular density, exudative versus atrophic. Loss of vascular density alone has a higher risk of atrophic AMD or advanced atrophic. But if you have a loss of vascular density, you're also increasing your risk of exudative or neovascular AMD. So as I mentioned earlier, I think we're moving in a path that subclinical diagnostics in a clinical optometry standpoint are going to include OCTA. So this is, I think, information that's important, that even if you don't practice at this mode right now, even if you don't have an OCTA, know that this is a valuable piece of your arsenal. And then just going quickly in here, I won't spend a ton of times on here, but 4 big types of choroidal neovascularization related to age-related macular degeneration. Type 1, big take home, the foveolae vascular zone, typically not involved. So we won't spend a ton of time because I want to get you to the data. And this is why it's so important for us at the subclinical primary care level to not let it get to this point. So type 2, FAS, almost always involved. And there's very heterogeneous shapes. So occult, FAS is not involved. Type 2 classic, FAS is involved. Retinal angiomatosis, angiomatous proliferation. This is where it can become kind of tricky because it begins really intraretinally. And when that neovascularization grows anteriorly and posteriorly, that I think becomes very complicated. And here is really the last. So mixed just makes sense, right? You have some that are above the RPE and you have some that are below the RPE. And this is where having that OCTA can help you identify where in that where in that choriocapillaris, where in that Bruch's membrane is that neovascular change. But the reason I bring up all of this is because certainly not an OCTA lecture, but knowing that if you're unsure, if you have that patient and you're being very critical of yourself to say, geez, I can't tell if it's progressing, I don't know for sure if there's changes. This is a very interesting device that we've started using the last couple of years at the university. This does have Medicaid health services endorsement. The company will, and I don't work for this company at all, they will help you work with a patient. And so this is using essentially a preferential hyperacuity, so a Vernier acuity. And this is a home monitoring system. Essentially, the system is dispensed to the patient, and the patient takes the test at home, and those results are sent to you directly through the software interface. And I think the important part here is the significant lead time in identifying a potential neovascular change. So this one I think becomes very important because right now our standard of care is an Amsler grid, and I'm going to talk about chart 1 versus chart 7 in a moment. But our current standard of care, if I'm worried about an increase in atrophic from intermediate to advanced atrophic, or if I'm worried about a neovascular or an exudative conversion, using the 4C in those high-risk patients that you really are very nervous about, they live a long way away, logistics of them coming back in is very difficult, or you don't know the next time you'll see them, really consider this because you can see the ICD-10s that would drive this, and the CPT, essentially it's not a reimbursable, but the company will work with you and the patient to help with this one. And so again, I do not work for this company, but I just want to let you guys know it's out there. If you don't have an OCTA and you're not able to manage that vascular kind of underlying risk factors, if you have someone who has all the boxes checked and you're worried about conversion to exudative, this might be a really nice option to consider for your patients that have difficulty getting back into the clinic. There we go. So polling question. So one of the last polling questions, there's only one left after this. What subclinical technique was described in the presentation as a functional assessment of macular function capable of identifying incident or early AMD before clinical signs are evident?
Okay, the question is open, and I'm sure the responses will be coming in here shortly. So,
and so just so I don't become an academic presentation assassin, I'll make sure I'm rolling in the right direction. So this list, it's not 100% comprehensive, and it will grow every day. But I put this out there because I think many of us, and especially even with the students I work with, they're like, well, if it becomes neovascular, well, then there's a treatment for them. It's intravitreal. Yes, there's risk factors, but there's treatment for it. Yes, there are treatments for it, but the reason that I would really urge you that our role, especially in the primary care role, is to do everything we can do to prevent it from getting here is because this was a really interesting study in 2023. So what it's showing is all of the anti-VEGF studies that we utilized for patient education, referral criteria, how we're managing that neovascular patient, when they looked at the actual clinically controlled data, so the RCT data and how much recovery you could expect, how much diminution of the neovascular changes you could expect, when they did real world clinical findings, it's about half of what you can expect. And the reason is life gets in the way. That patient won't always be able to come exactly at the 2, 3, 4, 6 month point. That patient will have a significant number of comorbidities that would have not necessarily been included in that original RCT trial. And that patient is going to have a logistical challenge, I'll say a nightmare, getting back in at high repeat visit criterion. So I say all of this because yes, anti-VEGF, it's a needed, critically necessary piece of the puzzle, but real world application, it's not going to give you as much bang for your buck as we had hoped And what we need to do at our level is try everything we can to prevent them from even getting to the point where anti-VEGF is necessary. Not always possible, but I think this is just an important underscore that shows real world data, and the anti-VEGF does not necessarily match what we know from the RCT trials, because that randomized controlled trial, it's a vacuum. It's a perfect world with, I mean, I hate to say perfect patients, but well-selected controlled patients. Real world, it's much, much messier.
So Chris, I'll give you
Yeah.
the answer here. Let me hit close the question, display. And 95% got dark adaptation. A few said ETDRS acuity, and one said spectral domain OCT.
Fair enough. Fair enough. So we'll keep rolling on this one, and we'll talk about my the
Mhm.
checklist that I use clinically in a moment. But here's where we talked about that systemic underpinning. So we've talked about the epidemiology, we've talked about the risk factors, but here's the evidence that I would encourage you to understand and know when you're working your patient up, especially from a subclinical AMD standpoint. So there's significant evidence that interleukins, so a lot of those inflammatory cascades, there are discrete interleukins that are elevated in an AMD patient versus a matched healthy control. So it's not saying that this is the only piece of information you need to know, but I think it critically underscores the importance of making sure you know your patient's inflammatory status. What medications might they be taking? What particular diagnoses might they have? Knowing if they are in a chronically oxidative, chronically inflamed state, that is a significant risk factor for not only development of AMD, but progression of AMD. And then I think the other one too is just discussing their cardiovascular status. So if we're going to discuss heart disease and stroke, really any of the heart disease are risks. So chronic kidney disease, congestive heart failure, myocardial infarction, the list goes on and on. But the biggest key is if they have heart disease and a stroke, look at that odds ratio, 6.3 times greater. That's a significant odds ratio increase for development of AMD. So that means they already have renal issues, they have significant cardiovascular issues. This patient is at big time risk for development of AMD and big time risk for progression of atrophic AMD. And the photobiomodulation I mentioned earlier, do not feel one bit bad if this is not something that you're quite familiar with. So I spent a little bit of time at the research lab here in town. Photobiomodulation, it's been out there for a little bit. It's been out there for a while in different domains, especially in the cellular imaging and cellular metanomics and genomics labs. But here I think is an interesting part, because photobiomodulation, you can see what it's trying to do. It's just turning on the mitochondria. What it's really doing is causing a decoupling of that nitric oxide, and you're causing the oxidative enzymatic pathway to turn back on. So it's essentially it's reducing some of the oxidation. It's that redox reaction that we all remembered from chemistry in undergrad. What it's really doing is it's allowing that cytochrome C to become a photoreceptor. So it's really starting to just turn the mitochondria back on, getting them up to full strength. And the important part is there is a commercial device out there. It is not currently FDA approved. These are European Union trials, but there's a LightSight 1. This is the LightSight 2 that I'll show here. There's a LightSight 3 data floating out there right now too, and it's very, very promising. I think this is that part where I hate to say it this way, but in the last 3 months, ophthalmology has noticed as well. So if you follow retina, if you follow some of the AMD publications coming out of JAMA and ophthalmology, photobiomodulation now makes up a number of their articles and review papers. So what I'm saying is, if ophthalmology is noticing, that means we should all be taking notice, because this is a technology that exists in the EU and this is on the horizon. And as Dr. Caldwell also astutely mentioned, this is the company that also bought the proprietary rights to Maculogics and their dark adaptation. So those two go hand in hand. One is a functional diagnostic and one is a functional treatment. And I think this is the important part, that you can start to not only remove the risk factors, but also do a retinal level therapeutic treatment to essentially reduce a risk, but also reduce some of the drusen leading to higher risk. So I think this is very, very exciting and very, very promising. LightSight 3 is out there if you are so inclined, the Cochrane database. And so you can hit me up with a question. I can send the email or the URL out there. But the Cochrane database, it's a meta-analytics site. So you go to Cochrane database, it's free to use. Type in these keywords, go to optometry or ophthalmology. Optometry has everything from convergence insufficiency to refractive amblyopia treatment, but it does a meta-analytics to say what is the clinical evidence and what is the strength of evidence, and it will show you where they are in photobody biomodulation right now. It's very intriguing, and this is something to keep your eye on. This is coming to a clinic near you.
And Chris, let me just make a quick comment on light. You know, I go to this meeting every year in Vegas. It's called the A4M. The 4A's are the American Academy of Anti-Aging Medicine. And it's MDs, DOs, pharmacists, nurse practitioners, the whole gamut, optometrists, ophthalmologists, blah, 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 blah. Thought they were getting into healthcare, and they were getting into sick care because everyone goes when they're sick. And if you want to learn about light therapy, or at least get more confused about it, there's aisle after aisle. I mean, they have hyperbaric chambers, salt chambers, supplements, gut microbiome, blah, 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 blah. But there's a ton of light out there. And boy, man, they really focus on it in this wavelength and that wavelength, and this one working on the mitochondria, and this one working on this and that, and so on and so forth. But this is where it might get confusing, is because, again, we grew up in an allopathic medicine. That's more functional because there's nothing opposite curing about light. You're using light to cure things or to treat things. So just try and help the audience out.
Yeah, no, absolutely. So the reason I want to bring photobiomodulation to the forefront is because this is something, based on the evidence I've seen, I have had a chance to chat with the manufacturers. This is something that you could utilize in a primary care optometry clinic. This is truly a treatment modality that, under FDA approval, this is something you could absolutely utilize right now, or when it does become FDA approved. And it's a whole different lecture, but FDA approval does not mean that you cannot, or the lack of FDA approval doesn't mean that you cannot use it. It becomes a clinical decision of risk, reward, and potential liability. So that's for a different lecture, but photobiomodulation, do keep an eye on that. That is a future treatment modality.
Yeah, that's basically, there's probably a lot of people on this that use red light therapy, use red light panels, or use red light sleeping bags, whatever. Same thing.
Yep, exactly right. So if you're into the LLT and IPLs, you're looking at the very same type of photobiomodulation pathways. This one is just directed at the retinal level. You're absolutely right. So moving into the nutraceuticals a little bit. So now that we've talked about the risks, we talked about the studies, we've talked about the subclinical and the clinical identification. What do I do about this? And so here is where we're going to get into exactly that. So here's just a nice chart that I like to keep handy on me. This is one of my handouts, and for everyone on the line, I have a number of handouts that I use for our fourth years, our residents, and that I use at lectures. If you would like a collection of all of them, I'll send them all to you. Just let me know. I'll have my email at the end. You can certainly reach out to me directly. I'll share them all with you. But this one I like because, as Dr. Caldwell had mentioned, the flavonoids versus the non-flavonoids. It does get very, very complicated in here. I mean, there are regions of study that are experts, top of sub-experts. My sister is a registered dietitian. She did her master's at Kentucky in essentially molecular nutrition. She talks about things that I don't even understand. So what I'm proposing here is trying to break it down to what the greatest amount of evidence supports and the easiest way to implement it into a primary care regimen. So really just stepping back, whenever you're thinking retinal nutraceuticals, whenever you're thinking what can be effective at the retinal level, I put the red boxes around. Essentially on the left, that's the retinal carotenoids. So we'll talk about the xanthophyllic carotenoids in a moment. And on the right, that's going to be the polyphenols. And so cyanidin, that's anthocyanin. So it's active component in blueberries. But the one key, it's those right there, hydroxyl groups, because that hydroxyl group is king. That hydroxyl group is what allows donation and acceptance of electrons. So when it's neutralizing a free radical, when it's scavenging singlet oxygen, this is what matters. It's that hydroxyl group, and the most effective retinal nutraceuticals tend to have the highest numbers of hydroxyl groups. And so now we're getting into what I loved and still do love and studied for essentially 3 years. This is where the rubber meets the road from a sensory retina deposition of the retinal carotid. And so, as I mentioned earlier, the optical hypothesis of why retinal carotenoids exist and where they exist, you can see that illuminated under green light, that's a primate retina, but illuminated under green light, there's very little absorption. So it's going to pass cleanly through, just a band pass, wide open, nothing going on. But if you use blue, and especially if you're looking at 460 nanometers, the peak absorption of retinal carotenoids, you can see not only the vertical distribution, but the horizontal distribution of that macular pigment. And I think the important part is, I'll come back to this at the very end, but the Mueller glial cells. So the Mueller glial cells are the most abundant glial cell. So essentially they're a support, like an astrocytic support cell at the neural level. Those are the glial cells that preferentially bind essentially the retinal carotenoids. And you can see that it goes right down the foveola. So it's right at the center of the fovea, and it goes straight down the foveola. And remember Mueller glial cells, because at the very end, we're going to come right back to why that's an important cell type and why it's really important that those cells tend to preferentially also bind the retinal carotenoids. So we talked a little bit about skin equals serum equals retina equals cortex. So if you were going to ask, is the retina a proxy for the cortex? The answer is absolutely yes. And we can utilize functional MRI or objective metabolic findings. So you can see that the higher the level of the retinal carotenoids, in this particular study, specifically lutein and zeaxanthin, as measured in the retina and as measured in the serum, you can see there's higher metabolic activity at those cortical regions. And for any of us who are optometrists and any of us who took our neuroscience back in the day, you can see how critically important those regions are. You can go all the way to the second to the bottom, the occipital lobe. The higher the retinal carotenoid status, the higher the skin carotenoid status, the higher the cortical status, the more metabolic activity is occurring in that brain region. And I think that's a really interesting tie-in, that if we can measure one of these carotenoid status locations, we can then by proxy understand that that must be either an adequate, a high, or potentially low in need of supplemental therapy to enhance or maximize the function available to that patient. This is the one where I talked about meta-analytics. This one, I would also say the jury, as I talked about the macular pigment, the jury is no longer out. This one is coming from back in 2021. It's all about what the retinal carotenoids do at the retinal level. So high retinal carotenoids, supplementation with retinal carotenoids, you can have an increased photostress recovery, you have a decreased glare disability, and you'll have enhanced contrast sensitivity. And the important thing here is it does have a lot to do with not only the amount of consumption, but the bioavailability. And I'll show some bioavailability and how you can research this on your own, because it's all about the bioavailability. Whatever it says on the back of the bottle, that's critically important. But even more important is knowing how much of that becomes bioactive, how much of that oral supplement or nutraceutical passes into absorption through micelle, through the serum, transported on a protein, crosses the retinal blood barrier, how much actually gets to the target organ. Bioavailability is king.
For a point of clarification, Chris, and since you studied in this arena, if someone measures low in carotenoids, which is one part of the whole antioxidant network, would it be just dumb luck that they're just low in carotenoids and the rest of their antioxidant network is just plentiful and perfect? Or would you agree that the rest of the antioxidant network is low?
I would agree with the latter. So yes, if you have reduced retinal carotenoids, it's a very safe bet that your whole antioxidant network is likely deficient. So there is absolutely synergistic effects on working on all of those levels. And the only reason that I was, I guess, picking on retinal carotenoids today is because that turns into an incredibly broad lecture. And I know how everyone online tonight would love to get back to their night. So I can nerd on that all day, but you are absolutely right. Deficient retinal carotenoids are highly indicative of a deficient essentially antioxidant network. They're all linked together. It's a big spider web of connectivity.
I'm going to let you run with this, but I want to make one more comment just so the audience knows where I'm going with this, is that this is what differentiates basically we as optometrists and ophthalmologists from the rest of the functional world medicine, is that the functional world medicine uses carotenoids, whether it's however they want to measure it, blood tests, macular pod density, the M-pod, whether it's these hand scanners that are out there, but they use it as a biomarker that if you're low in carotenoids, then they go and try and fix the antioxidant network, where we as ophthalmology and optometry, we just kind of play in replacing lutein and zeaxanthin. Now we're starting to bust beyond that and kind of get into that, but I just kind of wanted to point it out. That's why. So
no, you're absolutely right. So yes, that's a very fair point. And so just if I can narrow it back down to the retinal carotenoids, we talked about the hypothesized roles. We talked optical. We won't get a lot into neural, but protection primarily, especially from an AMD standpoint. I think this is the important kind of pharmacokinetics, kind of the basic physiology to understand that when you have a synergistic effect of not only all of the high antioxidants, but all of these retinal carotenoids, the xanthophyllic carotenoids in particular, they're essentially like stereoisomers of one another. So their slight chemical composition makes them slightly different affinities for their radical scavenging capabilities. And they are additive in nature. So when you can have a high one, if you can add a separate chemical structure in the same family, you get an enhanced effect. And the important thing I think that sometimes too is misunderstood is the retinal carotenoids, the macular pigment itself, is not necessarily consumed during the redox process, meaning that if you have a high macular pigment level, if you're exposed to a lot of blue light, essentially it's not consuming that macular pigment, that retinal carotenoid. What it's doing is it's donating an electron and then it's pulling it right back from another one. So it's a constant dynamic cycle out there. So I say that because macular pigment, in the absence of immunocompromisation, a high inflammatory or collagen vascular disease diagnosis, remains relatively stable if your diet, if your supplement strategy remains stable. It won't fluctuate up and down. It should remain relatively stable as long as you have that three-legged stool that Dr. Caldwell mentioned: rest, exercise, diet. If you can maintain that three-legged stool, the supplementation will show increases, stabilization, and it should remain stable unless there is a change to something in that cycle. I think from a protection hypothesis, this is the reason that I really was excited in graduate school, is because it was how the actual compound, how the molecule compound orients itself. So this plays from not only a protection hypothesis, but also into the neural efficiency and neurocognitive, because you can see that's the lipid bilayer. So that's the cellular membrane that encompasses everything. So that's the photoreceptor axons. Essentially, that's all of the microglia, that's everything, but it spans the bilayer. And the reason that it's so effective is because when it spans the bilayer, it promotes architectural stability to the bilayer and the cell membrane itself, but it also has those hydroxyl groups that poke into extra and intracellular space. So you now have free radical scavenging capabilities at a high level, both intra and extracellular. So there's a significant amount of value to get those carotenoid levels up because they're not consumed during the redox process, and they have intra and extracellular capabilities across the board. So now we'll start kind of wrapping it up. We'll start really pulling everything together right here. So we've talked about all the visual benefits, all the retinal health benefits, and not only age-related macular degeneration, but also diabetic retinopathy. But what about the systemic effects? And I think this is the part that this came out in 2022, but because we talked about the same capabilities to scavenge free radicals, to neutralize singlet oxygen as an antioxidant, the retinal carotenoids also have the same effect at the serum level. And so this is a part too, is just having, all of us having a science background, you can see that this is not a panacea. It's not a magic bullet, because if you ran your finger right down the center of both of those charts, you can see the left side favors carotenoids and the other side favors placebo. So In virtually all of the studies, it favors carotenoids, but it's not a magic bullet. It's not everything. So it has to be patient education, management of systemic disease, rest, exercise, diet. This is a whole network of things that you as primary care optometry need to know, that there are risks to what that patient is doing, and you have to make some lifestyle conversations, which are not easy, but how to really encourage them to make some of these choices and add that nutraceutical, to add that supplement, especially from the retinal carotenoid, polyphenols, the omega-3s, and also some of these antioxidant networks. And this one I'll put up there as well. It's lycopene, lutein, astaxanthin, and beta carotene. I put lutein, astaxanthin in there because astaxanthin, essentially, it's a chiral isomer to mesozeaxanthin. And so astaxanthin, if anybody has spent any time in the UK, they have something kind of unique over there. It's called tan in a can. Tan in a can contains astaxanthin, and astaxanthin deposits heavily at the skin level. Astaxanthin is actually why pink flamingos are pink, because flamingos are white birds to begin with. But the flamingo eats the crustacean who eats the green blue algae that has the carotenoid in it, and that's why they turn pink. But astaxanthin has a unique part because it gives you that highly desired orange Oompa Loompa look if you eat too much of it. So anyone with kids that have like the orange noses and the orange ears, it's carotenodermia. But that astaxanthin systemically is very similar to meso, and you can see that it has positive impact on diabetes, lipid, cardiovascular, and oxidative stress. So there is value across the board in increasing these retinal carotenoids because it has systemic underpinnings as well. And so now you're asking, well, what can I tell the patient? I put this up there. I pulled the table on the right, just came from a paper about 3 years ago. And this is the point where, yes, it is absolutely available in foodstuffs. Yes, you can have this dietarily, and it's important to get it from a dietary standpoint. But you can start to see, specifically to retinal carotenoids, it becomes very, very challenging to get everything from your carotenoids. And if you follow the food science over the last quarter century, Australia, the UK, the US, they're starting to find the nutrient density within a lot of our foods is just a little bit lower than it used to be. And it's not necessarily that there's a diabolical plot. It has a lot more to do with the logistical food chain of giving this many people a stable, stocked pantry, so to speak. So protein content in grains, nutrient density in fruits and vegetables is about 15 to 20% lower depending on the item than it was a quarter century ago. So what I say is, for most of the patients that I manage clinically, absolutely start with diet, but to get to the levels, and we talked about 20 milligrams in the past, to get to those levels, a supplement, a nutraceutical might be desirable and might be necessary to get to that level. So here we go into some of the take homes. Retinal carotenoids, you can see the top quartile. If I can get them as high as I can get them, peak neural efficiency, peak visual performance, so decreased glare sensitivity, better photostress recovery, better contrast sensitivity, and I can have mitigation of inflammatory retinal conditions, mitigating central serous, cystoid macular edema, clinically significant macular edema, age-related maculopathy. I can have positive impacts at the retinal level. And how long? Minimum 3 months. Minimum 3 months. But if I can get them to a carotenoid supplementation to get them out to 6 months, that is really where the data starts to show. That's where the measurable functional clinical tests will start to show positive trends and positive improvements. So I ask patients from the patient for about the first 3 months, but then I'm really trying to get them to that 6 month cut point, that waypoint at 6 months. I think, as Dr. Caldwell mentioned, absolutely, it's the three-legged stool: rest, diet, exercise. Without that, it's a nutraceutical, it's a supplement. It's not a replacement, it's a supplement. But those three are critical pieces of an integrated medicine and a patient wellness standpoint. I put this out there because this is from HEB, so this is a Texas grocery store. If you don't give your patients good guidance on what to select, it's just like saying go use an artificial tear. They're going to walk into the aisle, they're going to look at what you've recommended, and they're like, I don't know what any of this means, and they're going to start looking at the cost of the item. So making explicit, direct recommendations is going to change the game. That is really, I'll give a clinical snapshot of exactly what I recommend, but this is really where it's imperative that when you have that discussion with a patient, be direct and be explicit in what you want. And why is that important? Because I try to take all the names off of this, but this is the spread that when you go to the grocery store, this is what you're looking at. So on the left side, that's the AREDS 2 formulation. So that is what AREDS contains. So it has the high antioxidants and it has the retinal carotenoids in there. But if you go out there and say, get an eye vitamin, go get an AREDS 2 vitamin, if you're not explicit in exactly what you want them to use, they're going to start looking at price, and the price may be a little misleading. So you can see I put yellow boxes around what the daily recommendation from AREDS 2 clinically indicated in intermediate and advanced AMD is. And you can see going across there, it doesn't necessarily match all the supplements. It might be equal, but some of them don't contain the AREDS 2 high antioxidants. They only have the retinal carotenoids, and some of them will only have the high antioxidants, but not enough of the retinal carotenoids. And this will fall in, and you will see this time and time again. So I'm not telling you what brand to get, but I am recommending that if you are recommending a brand, know exactly how it matches against the AREDS 2 and make sure that line item by line item, that you're giving a recommendation based on the AREDS 2 criterion and the evidence-based medicine. On top of that, this one came out just in Retina of 2022. Just when you thought omega-3s, we couldn't figure out anything more. This one I think is important because the omega-3 literature sometimes vacillates a little bit. How much EPA, how much DHA, how much ALA, how much should I have of this? Should it be 3,000 milligrams? No, there's atrial fib problems. No, it should only be 1,000 milligrams. This one I think was very, very important because this was the first multi-ethnic cohort. So this was using a cross the board kind of ethnicity background that showed that essentially EPA levels alone were not significantly associated. It had to be DHA and it had to be EPA omega-3 fatty acids. And this is the first time that it had a racially diverse that increasing their omega-3 polyunsaturated fatty acids had a decreased AMD risk. I think that is really what I was looking for. So AMD reduction in risk does require an omega-3 supplement. And that omega-3 supplement also helps with the retinal carotenoids, not only transport, but deposition, because retinal carotenoids tend to transport. They have an affinity for HDL. They have carrier proteins. They tend to do a little bit better if you take them with the right fatty acid mix in their dietary take. And then right before we start wrapping things up, we talked AMD. I think I alluded to a little bit of diabetes, but this is another one. So there isn't a single one of us online that doesn't have multiple diabetic retinopathy patients and multiple hypertensive retinopathy. The retinal carotenoids in this online database, they did a systematic review, high levels of retinal carotenoids, even dietarily, supplementary. They have antioxidant, anti-inflammatory, anti-angiogenic, and neuroprotective properties. And I know the neuroprotection, that one gets a little dicey. Sometimes when I'm in the literature and I hear neuroprotection, my warning flags go up just a little bit. But from an antioxidant, from an anti-inflammatory, from an anti-angiogenic, because that has a lot to do with the protein expression at the allele level, carotenoids show value for AMD and diabetic retinopathy. So my very last polling question, this one, the AREDS 2 formulation has demonstrated clinical evidence of reducing the risk of AMD progression in what stage of the disease?
Chris, you mentioned a website earlier, and people are asking what was that website again?
Yes, if I think there should be two coming up in one moment. One is going to be the Consumer Labs website where you will show bioavailability, and the other one will be the NIH supplement website where you can also look at bioavailability. And thank you for listening that closely. I absolutely have those slides coming up in just 1 second, and they're both on the slides for you. So to get to those slides, I'll keep pushing. here's what I recommend. So again, being brand neutral, this is one where if I have someone who has high risk, no maculopathy, high risk, mild maculopathy, but not intermediate. If they have intermediate, I utilize this, but I also put them on the AREDS 2 formulation. But if I have someone who has zero maculopathy or mild maculopathy that is not indicated to use AREDS 2, that's my retinal carotenoids, that's my omega-3s, and then that's my polyphenols on the bottom. And so if you have any questions, you can email me directly on these things. I'll be happy to share what I use, but it gets to be too long a lecture. But the resveratrol, the curcumin, quercetin, and anthocyanin, those all come from in vivo and in vitro studies at the RPE level. So I left that space in there for a reason. The ones on top are your sensory retina target. And the ones in the bottom, that's your RPE target. So depending on your clinical acumen and where you think there's changes going on, if you're using dark addictometry, this is where I would really have you take a look at that.
Chris, you talked about, macular degeneration kind of being down at that RPE. We talked about the mitochondria. We talked about Brooks membrane. So it's also an RPE disease, or it's, Brooks membrane RPE disease. How much lutein and zeaxanthin are found in the RPE?
From an optical density standpoint, not a lot. But if you're using a high performance liquid chromatography, it's present. It's all the way across the eye. So yeah, that's a great point. Thank Dr. Caldwell. Don't misunderstand. The retinal carotenoids are found throughout the RPE. It's their optical density measurement is tough to identify clinically, but if you're using, and how many patients are going to volunteer for a retinal biopsy? Very few, but you can absolutely find those retinal carotenoids also at the RPE level. That's a very fair point.
So you got 79% saying intermediate maculopathy, you got 19% saying mild maculopathy, and then you have 2% saying no maculopathy.
Okay, very good. Very good. All righty. And then, so making sure I'm being respectful of everyone's time, I want to leave time for questions and wrap up, but I've only got a few more slides left. This is at Consumer Lab. You can log in. It used to be free. It is no longer free. You may have to sign up for a membership on this one, but this one will allow you to type in the supplement of interest, the vitamin of interest. Just thinking of a grocery store like Nature's Made or Puritan's Pride, you can type that in and it will show you in vivo bioavailability comparisons so you can make an informed recommendation to your patient. Same thing for the NIH. You can go to the NIH, and this is the dietary supplements. And this is where you can start looking a little bit deeper into recommended daily allowances, because that can also get somewhat complex. If you have any questions, I have additional handouts that I'd like to give to the residents and also my patients. So that way there's clear understanding of what the recommendation is. So what's now? Here's my last few slides. Here's the real big one. So we know this: family history, genetic predisposition, low carotenoids are all risk factors. We know that inflammatory, cardiovascular disease, those are the big risk factors. And that risk is not static, it's dynamic. Your lifetime risk changes if you are diagnosed with age-related maculopathy. The moment that first drusen shows up, the very first time that dark addictometry shows findings consistent with age-related maculopathy, your risk dynamic changes. And that was one of those first 6 slides. You can see the well-established link between the retinal carotenoids, the systemic disease. There's a well-established link to mitigation of systemic disease. I think the other one too is, it's outside the course on this one, but we have some work going on with Penn right now on early evidence following MTBIs. And so being very, very open and transparent, we're talking about mild traumatic brain injury. So this is GCS or Glasgow Coma Scale of 13 or above, 13 to 15. This is not for your moderate or severes. This is the concussions that tend to have non-resolution over a number of months or tend to have lingering symptoms. There is, because of the retinal proxy at the brain level, you know that it's embedding within these neural substrates and these cortical levels, that MTBI can also be ameliorated to a certain extent utilizing these retinal carotenoids. So as I started the whole thing off, this is what we talked about. even if you don't have a dark adaptometer, even if you don't have spectral domain or OCT, you don't have any of the fancy equipment, this is contrast sensitivity. Peli-Robeson, precision vision 5%. This was that, I think, argument that I would have with sometimes in discussions with clinicians, they would be very concerned, like, but they have cataract. So how do I know if there's a difference between the loss of contrast sensitivity, if it's a cataract or if it's AMD? And it's the significant precipitous drop off in a short period of time. And the reason I say this is because if you're grading at a 1+ NS or a 2+ NS, and you see them, and then you see them a year or 2 years later, you can see that logmar is on the bottom, and then contrast sensitivity is the ordinate or the Y. For a cataract, you can see that there's a negative relationship, so it does increase. But if they have an age-related macular degeneration, if they have a maculopathy, it's precipitous. Their contrast falls off rapidly compared to their logmar. So I think this is just one of those, you can do this in your clinic, set the bar, and I'll show you the exact change on the logmar in a second. But the important part is how much is something. So I'm doing my Peli-Robeson. How much contrast sensitivity am I worried about? 0.3 log units. And the 0.3 log units is clearly indicated on the Peli-Robeson. And that's my very next slide. But 0.3, if you're going to remember nothing else, that's the amount of change on the Peli-Robeson you want. And you can increase their visual function questionnaire. So the question is, what is 0.3? On the right, that is the green and the red boxes. That is essentially each 3-letter grouping is 0.15 log units. So statistical or clinical significance is a grouping of 2 change. So if you go from ZVR down to OSK, that is a significant increase if you go up. That's a significant decrease if you go down. So that is really kind of your trigger. If they're going from CKR over to ZVR, that's a little bit of nuance. Is there a change there or not? But if they are losing 2 full 3-letter brackets, that is a clinically significant, meaningful finding that you need to track down. This one I will only put up there for interest. That's how you code AMD. Everyone can take this for reference, but you can see that OCT and OCTA are both 92134. If you're doing one, you're doing the other. Fundus photography, color fundus photo, fundus autofluorescence. In some cases, you can code for the same on the same visit, but they have to be for distinct disease entries. I say that because go to that website. That website is a very nice starting point. You can go that. Everything on the left with a cataract, corneal abrasion, foreign body, it will actually walk you through how to code it, what to do for a CPT, and what the follow-up is. So if there's another slide to take a look at, that's what I would incur. And then this will be one of my last ones. This is another one you have in your clinic right now. Amsler grid is the standard of care, but this is chart 7. Take a look at chart 7 because you can increase your resolution right at the fovea. This is when you can really find those small little changes, and especially AREDS 2 criterion with a small Druze change, you need that enhanced resolution right at the fovea. And then we won't talk too much about this in the interest of time, but these intraretinal hyperreflectivities, these are going to be the big warning signs. If you start to get, these are not neovascular changes. These are RPE cells that have migrated in. If you did easy disruption and you get RPE migration changes, that's a big risk factor for increased risk of advanced atrophic. And then I put this up there too because the double layer sign. I think a lot of us see this, but here's the evidence that if you start to see a split between the RPE and Brooks, that's a big risk for increased intermediate and atrophic. And then talked about, these are the FDA approved. I don't know what your retinal specialists are saying, but my retinal specialists, they're not all in on this yet. There's some reservations on how active they want to be with this. And you can see that's the first one in February. And this is the one that I think was causing consternation. Yes, it's effective. It shows FDA approval, but you can see it increases neovascular risk. And you can see that it's not an insubstantial amount. There's some risk that you're inhibiting the compound factor 3, but there's still a neovascular risk.
Chris, let me just make a comment. I know you're trying to land right on time, and I appreciate that, but go back a few slides.
Sure.
Synfovre and Izervay, these are the new molecules that are out. I want the audience to realize for geographic atrophy, that's what you see Fonzie on TV, always talking about geographic atrophy. This is dry, but I want everyone to realize these are not biologics. So these are very different type of molecules, not biologics, used for dry macular degeneration. And like you said, the jury's still out, at least on Syfovre here, because of the increase in neovascularization, and it's also happening with the Izervay, but maybe not such a higher rate. But you're catching these people when they still have great vision, but it's then what we're thinking injections for life. But these are the new ones that are out there. So.
You're absolutely right, and that's why I think if there's a take home from this, and thank you, Dr. Caldwell, do everything we can to prevent them from getting to this level. You're not going to stop everything, but it's a number needed to treat. Do everything you can to mitigate that inflammatory, high oxidative stress to get them to not need this. Just going straight into this. This is for everybody. I will send this out immediately afterwards. If you would like this, this is my checklist, my pilot checklist, if you will, for clinical management of AMD. What's next? If the brain equals the retina and the retina equals the serum and the serum equals the skin, these are two of the devices on the market that can measure skin carotenoid levels and are fairly repeatable and robust. And I think these are some of the very interesting ways forward to identify at a population level, primary care screening. How do I identify those patients that would respond and have the most to gain by a carotenoid supplementation regimen? And then we talked a little bit about this. I think here, this is my last 3 slides. This one is really, really big because this came out last year. Our clinic was inundated because when this came out on CNN, everybody wanted to know, do I have Alzheimer's? Maybe. So there's not a way to definitively say you do, but it's a risk. And as I mentioned, the risk that I talked about is you can see the microglial cells in that periorbital gyrus and that hippocampus. Where do mular glial cells live? They live in the retina. And because they're an astrocytic support glial cell, they also bind preferentially to retinal carotenoids. So there's a connection. There is a link there. This is better saved for a different lecture, but there is a link for what the retinal carotenoids, polyunsaturated fatty acids, can do from a reduced risk in neurodegeneration. Additionally to that, in Alzheimer's disease, those AMD drusen tend to have a beta amyloid core. Here's some research, and I don't want to talk too much about this. I have one last slide. There is evidence. Be very, very strict about where you're finding these drusen, because if these drusen are starting to show up in the arcades or outside that normal macular area, and it's increasing over a 1-2 year period, there's some evidence out there to believe that these drusen have a beta amyloid core and may be related to some of the Alzheimer's or related dementias. Very last slide. I won't read it to you because I won't insult anyone's intelligence, but I think there is, from primary care optometry, this is our time. I think we can make significant strides. We can increase the quality of life. We can make a difference across the board in so many patients. Be critical. They're guilty till proven innocent. Use your subclinical skills, and you can make a difference in delivering that healthcare that we all can do right now. And so with that, I know I talked fast to finish up. I just want to be respectful of everyone's time. There's my email address. Send me an email if you'd like anything from me whatsoever. I think the slides, as Dr. Caldwell mentioned, are available for download, but you can reach out to me for any of my clinical handouts, any of the things that I utilize and in clinic and with the residents. Reach out to me right away, and I'm more than happy to share. So with that, thank you very, very much for everyone's time. I really appreciate being in.
Thank you, Chris. That was fantastic. I like the evidence-based medicine approach you have to it. And we're all caught up on chat. No further questions.
So Chris, if you'll let me share.
Yes, sir. Let me take that down, dropping down.
So thanks everyone for taking the course.
Okay.
Let me share. What I want to point out to everyone is right now, if you go right here to survey, you can complete the survey, or you'll get it in 6 minutes to your email, but you can complete the survey here. With that being said, Chris, you did a wonderful job. Questions have been answered. Thank you. This was Advances in Diagnostic Treatment of Atrophic AMD. Chris Putnam, as you could see, the PhD side of him coming out with this lecture. But what I love about Chris is he also brings it right back to the clinical. So like Joe said, great research out there, kind of the crux to evidence-based medicine and allopathic medicine, maybe not used so much in functional medicine, but Chris, that's going to be a lecture we're going to do someday.
Love to. Let me know.
So thanks everyone for taking it.
Awesome. Thanks, guys.